Hey, this is Andy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For our education episode this week, we are going back to the surgical series. And in particular, we're going to focus on, I feel like, something that doesn't get talked about a lot.
And that doesn't get surgery as often.
Yeah, which is ironic, that surgical series, but still works because we did talk about surgery.
We did.
A little bit.
We did.
We are talking about spondies.
Bah, 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 bah.
You did it!
I stole your thunder.
That was awesome. Holy smokes. I'm really jazzed. I don't know if I'll be able to keep going now. That was awesome.
You want to introduce someone even more awesome?
Yes, I do. And in particular, if you're looking for spine stuff, this is the guy. We interviewed Dr. Nitin Bhatia. He serves as the Chief of Spinal Surgery and Chairman of the Department of Orthopedic Surgery at the University of California, Irvine. He has published more than 50 peer-reviewed articles.
Randy's favorite.
Yes. And in particular, like, this was kind of like really kind of big news, was they just recently published a massive study on the management of spondy pathologies within adolescent athletes, or, active populations. So it was really cool to be able to like sit down and have a conversation with them.
And this topic is super conversational, and I think that's what makes it so accessible. We talked everything from the beginnings of when to send to a physician. We talked all the way through how long a brace should be considered, and then once the brace comes off, what kind of rehab we're talking about, and then the return to play. So we really take this like from the beginning all the way through, as we would see as athletic trainers. So This is a really valuable podcast interview that we did, that is honestly probably one that has a lot of applicable takeaway items.
Yes. Yeah, it definitely hits, our goal of our podcast in general is just, hey, we're trying to get applicable information.
Mm-hmm. So without further ado, let's get started.
Let's roll. So when a patient comes in just complaining of low back pain, like that could be anything and everything. But what are some like complaints that a patient may have that are kind of key to identifying an actual spondy pathology?
Great question. So I'll tell you, a lot of it depends on who that patient is. So adults always get back pain. It's who we are. I always say it kind of, excuse my French, but it sucks to get older, but it happens to all of us. And for most adults, the number one thing is it's a muscular issue, right? We need to stay in shape. We need to exercise. We kind of take it for granted in our teen years, in our 20s. We can take days off and it's fine. But you get to your 30s and 40s, you really need to be doing 5 or 10 minutes of core pretty much every day. Now, when we're talking about spondy pathology, meaning spondylolysis or spondylolisthesis in general, those are very specific issues. And the term spondy means spine. So lots of things we talk about the spine use the term spondy. So spondylosis is one you may commonly hear, and that just means degenerative changes of the spine. It's essentially arthritis that everyone gets. If you get scans on 100 men aged 20 years old, more than half have degenerative arthritis of their spine already. Not meaning it causes pain or problems, just meaning that they get this spondylosis. Now, one of the problems that kind of we abbreviate in medicine as a spondy is a problem, a pathology we call it, where the bones actually start to shift on each other. The most common way they shift is the bone on top will shift forward, meaning kind of into the belly over the bone on the front. And that's called a spondylolisthesis, sometimes also called an anterolisthesis, meaning shifting forward. Now, there are multiple kinds of this spondy and spondylolisthesis. There are some that come from arthritis as we get older, people in their 50s and 60s, some that kids are born with, which is very rare, some after terrible car accidents, again, very rare. Another common kind we see is one where young teenagers actually have an injury, a fracture. They break the bottom bone. And in a 13, 14, or 15-year-old, you can see that bone slip. And it sounds very dramatic, right? They're breaking their bone. But guess what? Young teenagers who are playing sports, sometimes they hurt, sometimes you just play right through it and keep going. And so it's important for us. The question was, how do we start to worry if something might be a spondy? Well, especially in these younger patients who are in their teens, if they're stopping their sports, if they're saying, mom and dad and coach, I can't play, and they normally play through their aches and sprains like a lot of high-level athletes do, boy, we better think there's something going on there, because teenagers, adolescents, kids, they don't stop playing unless they're really feeling it. And so that's when we start to be concerned. And a lot of times that's when patients show up in our office and their parents say, John or Jennifer, whoever their kid is, they've always played, they play hard, but boy, they just couldn't keep going at this point. And that's when we start to be concerned that there's something structural going on, like a spondylolisthesis.
Clinically, when you're noticing these, either one, what differences have you seen that might differentiate a spondylolisthesis from a spondylolysis?
That's a great question. And again, the word spondy everywhere meaning spine. And so listhesis means the slipping. Lysis means the break, that you're actually breaking it. And so in these young teenage athletes, the lysis is what occurs first when they have this. They actually break the piece of bone that connects the front of lumbar 5, or the lumbar 5 bone, to the back of it. And that piece of bone is called the pars, that's P-A-R-S, interarticularis. Essentially, it's the part that connects the two joints. So that breaks, and it breaks particularly at that age because of the growth those young teenagers are going through and the changes in their muscles and their bodies. And at that point, a lot of them are also starting to do much more aggressive athletics and activities. So all of these changes kind of come into play. You actually don't really see this injury in adults, and you don't really see it in young kids, meaning 5, 6, 7 years old. It's truly from about 11 to 15 or 16 years old. And so the first thing that happens is the lysis. It's the breakage. It can happen on one side, either the left side or the right side of the spine. So either unilateral or bilateral. It can happen on either left or right side. There's no predominance of left or right if it's one side. They're pretty much the exact same number. If it happens on one side, it can actually heal. But if it happens on both sides, then the bone can slip forward and the lysis can turn into a listhesis, the spondylolisthesis. So when we're seeing the patient, based on what they tell us, it is very difficult to know if they have a listhesis, meaning it's already slipped, or if it's just broken. Because they often just come in and say, boy, my back hurts. It just started hurting. I was lifting weights. I was playing football. I was doing my gymnastics, tumbling. And I felt this sudden back pain, and it's just been hurting me on both sides. So it's very hard to tell without an x-ray or some sort of scan.
Okay, that makes sense.
Yeah, perfect. Does the level of the spine kind of affect how each pathology is going to heal?
Yeah, it does. And in fact, what we see is certain levels are very predisposed to certain kinds of injuries. So this spondylolysis and listhesis that we're seeing in the younger athletes, that's called an isthmic spondylolisthesis. It's one of the kinds. And that occurs much more commonly at the bottom level of the spine. At lumbar 5 is where the fracture occurs, and the slippage is at lumbar 5 sacrum on the very bottom level of the spine. Interestingly, the most common level for the arthritic or degenerative spondylolisthesis that we see in older patients who may also be very active in their 60s and 70s, playing tennis or pickleball or golf, lots of the things we see in our active population. The most common level for that is lumbar 4, lumbar 5, actually the level above. And you uncommonly see it below because of some of the different anatomic characteristics. So in fact, when we see someone with the slipping at lumbar 5, sacrum 1, we almost always presume it's the isthmic type, the type they've had since they were a teenager, that's maybe gotten worse if they've gotten older, until proven otherwise.
So when you have someone with a spondy pathology, when is it indicated for bracing?
Great. So bracing is really good for two things. Number one, if someone's really acutely inflamed for some reason, some short-term bracing can be used. But I will tell you, in general, we try to avoid it just for muscular issues because it allows the muscles to decompensate and actually become a little bit weaker. And so it becomes a bit of a cycle. Now, if someone wants to use it once in a while when they're doing certain activities, that's different. We don't want to slap braces on people consistently unless we know what's going on. It's, as athletic trainers, so much of the body is how the body functions. And while the bones and the joints and nerves are obviously super important, the muscular function and lack of muscular dysfunction is what really determines spine health in most people. Now, for someone who comes in with an acute or sudden onset of back pain, especially these teenagers who are playing sports, and we get X-ray or a lot of times we'll get an MRI scan as well to see if there's the spondylolysis or listhesis. If we say, hey, this just happened, then a brace can be very helpful. Okay. Because what you're trying to do for those patients who it suddenly happened to is actually restrict some motion. Now, it's not going to lock them in like a surgery with screws and rods, which of course is a whole different level of treatment, or like a cast for a broken wrist or broken arm, but it stops some motion and reminds these patients, hey, while your body's cooling off this suddenly fractured bone, you shouldn't be doing the things that perhaps you want to be doing or that you've been doing in playing sports previously.
Okay, yeah, that's interesting because I was going to say, yeah, I've seen it kind of like managed differently where, some I've seen, hey, they didn't really recommend the brace, and then some like, yeah, no, this athlete's probably going to need a back brace for it. So it is interesting to kind of see that side of it.
Yeah, it is. And for years, it's been a bit of a lot more. We talk about the art and science of medicine, right? And we know the science, hey, we know it's a spondylolisthesis, but art is, what does that particular doctor do? Our group just published a big paper looking at the biggest group of young athletes in America with this exact problem. And we treated them all with bracing. So they would show up with acute onset, would diagnose it with x-rays and an MRI scan. And then all of the young athletes, meaning kids in their, from ages 11 to 18, would have to be in a brace for 3 months, 23 hours a day, and shut down all athletic activities, which is hard for a high-level athlete. We're talking about junior Olympians. We're talking about kids who are going to Division I college sports. We're talking about really high-level athletes, and that's one of the hardest things is having that heart-to-heart conversation with them and their parents and their coaches about the importance of this. And so for those patients who have the sudden structural injury, this break, a brace can be great for usually up to 3 months. After that, we really try to get people out of a brace if possible to prevent further muscular deconditioning if we can.
And they're doing physical therapy while they're in a brace?
Yeah, so interesting. Some of the old protocols do talk about that. It's a very focused physical therapy. Actually, the newer protocol, including ours, has them completely shut down. So no physical therapy. Okay. Really, you can walk around and do basic stuff that other people do who aren't athletic, and that's again really hard for them. But especially if they're in school, it's going to class, it's doing your homework, and that's about it. There's no stretching, no physical therapy, nothing for 3 months. You're completely shut down. And then at the end of the 3 months, most of them, their symptoms have really cut down to essentially nothing. We then get them out of their brace, and that's where really structured, gradual return to activity with our athletic trainers, with our physical therapists, is really critical to get them back in a safe and functional manner.
And I know during that period, there's also limitations on the amount of weight that you can pick up as well. So, right. So you're looking at, especially when we're dealing with student athletes, you're thinking of the backpacks.
Oh yeah.
Yep.
Instead of carrying the backpacks, you might need to switch to a roller backpack and
Right.
some other things that might be out of what we're thinking day to day in like just sport activity, but also like that
Right.
this athlete's also a student.
Yeah.
Right. So if you can figure out a way to get these student athletes to use a roller backpack, I'm going to follow your advice.
I was
Because
just thinking that. I was like, man, I think that's probably the most upsetting part right there.
it's so hard, and you see these backpacks, and the amount of books that kids have, and yeah, they've got a computer in there now, and they've got still have the books, and I think 20 to 30 pounds is not uncommon.
Oh, I bet.
And the position statement for the American Academy of Orthopedic Surgery, if I recall it correctly, is that it should be at maximum 10% of your body weight. So we're talking for most kids 10 to 15 pounds maximum.
Yeah.
Right.
And so now we're talking about kids who have a back injury that's real, and carrying around a 30-pound backpack, and we tell them, hey, get a roller bag and roll it around campus. And they say that's the first way to get the roller bag thrown at them or get beat up and behind the gym. And so what we try to do is actually to try to work with them through it. And sometimes we'll give them a note for a second set of books they keep in their locker and one at home. So they just don't have to be carrying stuff around as much for at least 3 to 6 months. But it is tough to get teenagers because of social pressure to do some of the things we recommend. Even wearing the brace 23 hours a day, it's hard, right? You show up in school in this big contraption. They may wear it out of their house and they may put it in their locker first thing. So it's we just try to encourage them and try to get them to do as much as we can.
Yeah, it doesn't have the cool factor to
it does not until it's on TikTok, and then it'll be a whole cool thing for them, I guess. But until someone makes it the right thing to do or the cool thing to do, I think we're going to we'll keep advocating for it and keeping our fingers crossed that someone listens.
Oh, for sure. Yeah. So when it comes to that all right, it's time for the rehab part. What are some things that the athletic trainer should focus on in that rehab aspect?
Yeah, so I think, this is where having an athletic trainer, everything from in the office to someone the patients see afterwards, is really game changing. We're lucky at UC Irvine. We have an athletic trainer who works hand in hand with our sports medicine team, including myself. Once these athletes are progressing on, they'll go see that team as well to get back to sport. And one of the hardest things is understanding this is not an instantaneous on and off, and getting the athletes and again their parents and their coaches to understand that getting back to it is a 6-week, 2-month, maybe 3-month process to the level of activity you want to get it. Now, I will say almost all athletes, not 100%, but probably greater than 90%, do get back to their high level of competition. And actually, rarely do they lose a step. When I talk to most of them 6 months or a year later, they're back to where they would have been anyways. Awesome. Their body's grown, they've matured, they've still kept up on the theory of the game, that sorts of things. And they catch up quickly to their peers. But that initial time, they want to go out and swing as hard as they can and throw as hard as they can. And their body's not ready for it. Even if their spine's safe, their muscles aren't ready for it. Their other joints aren't ready for it. And so working with an athletic trainer to set a protocol that there's a goal somewhere down at the end with an understanding of how to build up to that ultimate goal in a designated or approximate time frame, I think is really important for the process.
I think we touched upon the patient population, but I think it made me think of what sports you've kind of seen this most prevalent in. Have you noticed a certain, like gymnastics mostly? We talk about that a lot, but
Yep. So you hit on one of the biggest, most classic ones is gymnastics. And so the kinds of sports that cause this is repetitive hyperextension, so bending backwards of the low back. So gymnastics or cheerleading, even class ones, because of all the
Mm-hmm.
back flips or back tumbles that they do.
Mm-hmm.
In more male-dominated sports, in football linemen, because they're pushing up against each other. In fact, a very high percentage of NFL linemen have this spondylolysis and spondylolisthesis. Other sports that have it, it's interesting. I call them the California sports. So high-level surfers, because they're extending their backs a lot to make turns. Volleyball players in California, because they're extending their backs, especially the big hitters. We see it a lot more out here. And one of the things we found out recently, again in that paper we worked on, is that many of these injuries don't occur during the season. They actually occur during the off season, when the athletes are working really hard in the weight room and pushing their bodies to that next limit. So the majority of the injuries occurred in the off season when they were doing weight training and strengthening. And again, these are high level athletes. So it's not just that they're doing some, going to the local gym and doing a few minutes of cardio. They have a strength coach, they have a weight room, they have a fairly intense protocol to get ready for the next season. And that's where the majority of injuries occurred. Actually, was in that off-season time rather than truly in the sport, where there's probably less of this rapid hyper extension and repetitive hyperextension, at a high level of weight, that's kind of stressing the body to the limit.
I'm glad you brought up like those kind of like the different sports. Does the type of sport change that kind of return to play timeline? Like if you have someone who's like a gymnast, like, hey, is this going to be a little bit longer than maybe say like a basketball athlete or an NFL lineman or something like that?
Yeah. They're pretty similar actually.
Okay.
And you're right. It kind of almost seems like a gymnast. You see the things they do and it's superhuman. Not that the things that are basketball players and that you still do aren't superhuman, but it's a different level, almost a different level of physical stress in a different way, so to speak. But no, they actually get back pretty consistently. After the 3 months off, usually I tell them it'll be about another 3 months to get to the level you want to be at. And that tends to be pretty consistent. There's always some give or take there, depending on how high their function is and what they're trying to get back to, and maybe how long they were off before the diagnosis was made. But in general, it's pretty consistent.
Okay, perfect.
So we talked about how once we send someone with back pain to you, and you kind of you do your own evaluation, and then you do get further imaging and look at, okay, is it like what type of spondy is it? Once you determine what type of spondy, do you have a different treatment plan depending, or do you have some indications for when surgery is needed?
Yeah, great question. So there's really 5 main kinds of spondylolisthesis. We talked about the most common is the degenerative arthritic. So that occurs most commonly in women over 50 or 60 years old. They can occur in younger people and can occur in men, but it's a 3-to-1 women to men ratio. And that occurs because of arthritis in the small stabilizing joints called the facet joints. And actually, that can cause back pain, but also shooting sciatica pain as the nerves get pinched. The second most common is the isthmic kind, and that's the kind we've been talking about for most of this podcast. It's been the younger athletes. This injury occurs. It's a fracture in the lowest level, lumbar 5. Tends to occur when we're teenagers. Sometimes first shows up maybe some years later, but that can cause also back pain and some leg pain. And then the other 3 less common include what I call congenital, dysplastic, or traumatic. I won't really talk much about those because they're very uncommon. Really, the question about surgery, I'll divide it up into the 2. So the degenerative arthritic, which is, again, the older patients, it's really a quality of life issue. So if someone has it, but they're doing fine, they're remaining active, playing the sports, traveling, working, just keep an eye on it. If, however, they're starting to get the sciatica or what we call radiculopathy, which is nerve pain, if it's coming from that same spot, that's where we're looking at other treatments like therapy and injections, and surgery can be helpful. Interestingly, studies looking specifically at this degenerative spondylolisthesis once people have the nerve pain, really the only treatment that provides long-term relief is surgery. Whether it's therapy or medicines or injections, they provide some relief temporarily, but the degenerative arthritic process just continues and progresses with time. And so it's really the only permanent solution to surgery. In big studies that the government has funded, because it's pretty common, have shown surgery works well. Of course, I'm a surgeon, so I say that. But it's one of the things that actually is very clearly indicated that patients do really well. Surgery recovery is very good. The patients in general are very happy, but it is real surgery. Now, the isthmic is a little bit different. Again, it's a younger patient population. It's not really degenerative arthritic. So if we can calm it down, most of these patients can do pretty well their whole life. So they show up to us when they're 14 years old. They have the break. We put them in a brace for 3 months. Their pain gets better. Then we start them on therapy. They get back to their life and their sports and everything. The majority of those patients, yes, they will always have the break. They'll always have the spondylolysis. They'll always have the slippage if they have one, the listhesis. But they can live a very functional life normally forever. A small percentage of those 20 years later, usually when they're in their 30s or early 40s, will have more accelerated degeneration and arthritis at that one level, just more stress. And some of those will come to us with back pain and leg pain now in their 30s. They've had 20 good years. They literally have had no issues. And now it's kind of just worn out and they may need surgery for that. But most of those patients actually do quite well without surgery, versus the degenerative ones who actually, many of them do end up needing surgery to stop it. So really, for both groups, though, it really comes down to quality of life. It's rarely something that we say, hey, you have to have this. If someone's getting weak in their leg or foot, of course, that's something we want to be more aggressive about oftentimes. In both of these kinds of spondylolisthesis, you can get weak foot or what we call a foot drop. In both, it's fairly uncommon, but it does happen. And so really quality of life, but probably we operate on significantly more of the degenerative spondylolisthesis as patients get older than we do the isthmic.
Okay, interesting.
I didn't even consider injections, but I guess when you were talking about radiculopathy, that would make sense and you said that it kind of, some people have found that it helps, and then ultimately if it doesn't, then that's kind of when surgery would be next step.
That's exactly right. So especially for the patients with the degenerative, we oftentimes will try it, and that's so you get a year or two, and maybe you come back then and you need surgery. But hey, you've got a year or two of good quality life without having a surgery. So I think most people would take that for simple injection.
Most definitely.
For the younger, again, the isthmic, the younger kids with the spondylosis, we oftentimes do not need to do injections. That's a minority of patients. Most get better just with the activity and modification. But if someone has persistent pain, then we may try an injection. And of the patients who get the injection, the vast majority of those get better with that. And so the percentage of patients who need surgery for the isthmic is probably less than 1%.
Okay.
As they're younger, as they get older to be adults, things change. But you in that first time when they come to see us and they're playing sport and that sort of thing.
Awesome. So we've really focused on, hey, here's what we're looking to do. Here's where our rehab's going to focus. What are some just key things that while we're going through that rehab process that the athletic trainer should keep in mind to avoid?
Yeah, so that's a great question. It's one that I get often from our rehab teammates as they're getting these patients back. So one of the things that really irritates this is an injury from repetitive extension or backwards. And so that's probably the last thing we want to get in there. So even when we get our players back doing things, for example, I mentioned people who are hitting things overhead, tennis players, volleyball players, they extend back when they're serving. They extend back when they're really hitting. That's the last thing they should be doing. And so not saying last thing is dangerous, but the last thing as you progress along the rehabilitation protocol, just because that'll tend to flare them up more than a lot of the other activities. So probably avoiding the repetitive extension in the initial phases of rehab. And I should say, especially forcible repetitive extension. So if it's very controlled, trying to just work on the rehabilitation of the muscles, that's a bit different. But going through things that are a higher level of stress, a higher level of kind of muscle contraction, I would avoid at the beginning.
Would you say that on the opposite, is it safe to be doing, in addition to just like bracing, is it safe to be doing flexion activities?
Yeah, so once they stop with the brace at 3 months, we get them into therapy, and that's really the next phase. Now we've stopped the muscle break from being painful and symptomatic. Now it's getting the muscles back to being healthy again. And so getting them back with, flexion and basic core strengthening and kind of overall holistic body rehabilitation. Because again, they haven't done anything in 3 months. This may be the first time that a lot of these teenagers haven't done anything in 3 months, probably for their whole life. And so just getting them back to being active again is really the key. And then again, it always reminds me when I see how well they recover that it's great to be a teenager, because you once we do get you back there, they may recover amazingly well. But it is a gradual process to get the whole body back into it.
Are there any points in rehab that there are any red flag symptoms that, I mean, obviously they're going to be doing follow-ups with whatever physician they're going to, but are there any red flag symptoms that you would say to an athletic trainer, if this happens during rehab, they really need to go back and get evaluated again?
Yeah. So, the things that I expect them to be a bit sore and tight. The things that I think red flag, I always say about the spine's pretty obvious for most things when there's an injury. And so a significant increase in pain, that's not just, hey, I'm sore. I was sore after our option, but boy, it hurts. Development of sciatica or, shooting leg pain. That's another one. Those are the two that I'd probably be most concerned about. And again, it's pretty uncommon. It's not uncommon to have little flare-ups as you're increasing. I would say recovery is never this straight line. It's more like the stock market. You get better, you have a little bit of flare-up. It's kind of this up and down roller coaster pattern as you do more and your body kind of responds to it. But it's when some boy says that's not just sore, but boy, that hurts. And now I'm hurting afterwards, especially with leg pain. That's when we start to worry a little bit. Maybe we then slow down the rehab, maybe put them back in the brace for a month. Maybe you get a new X-ray or MRI scan to take a look. One of the other things I think that's important for our patients and our rehab team to know is one of the ways the body responds to this spondylolysis and spondylolisthesis in these young patients is it tightens the whole spinal, pelvic, and leg chain. And so hamstrings become very tight in order to stabilize the pelvis. And so when you try to stretch out these patients' legs, even in these gymnasts who are highly flexible, they can't straighten their knees. Their knees are literally bent a little bit. And that's because the hamstrings have become tight to try to shift and rotate their pelvis. And no amount of therapy or stretching can untighten them until the body's ready. And then one day they'll wake up and it'll be loose. But so it just happens. I've seen patients come back and they're in zero pain and they feel great, and the body's just not ready to let those hamstrings loose again. And so for most athletes, it's not a big deal. They just deal with it. What it does, it just verts the pelvis, rotates the pelvis a little bit, and the body handles it. So it's actually not a big deal, but it is something that is not changeable until the body's ready to change it.
Body finds a way.
It does. It's amazing.
I mean, just goes to show how you can't just treat the area. You have to treat above and below. I mean, the whole body in general, but.
It's interesting, because you mentioned that, and it's something that I think, as surgeons, we get very pigeonholed into our specialties. I'm a spine surgeon. That's what we do. And in orthopedics, we have hip surgeons. You've had my partners on. One's a foot and ankle surgeon. One's a sports medicine doctor specializing in knees and hips. Another one's sports medicine doctor specializing in shoulders. So we end up in these little areas. And I think for years, we haven't looked above and below. And now we start to look at the body in a more holistic manner. So for spine, now we talk a lot about the pelvis and the hips, and alignment with the lower extremities. Even in the neck, we're talking about how the neck aligns with shoulders and other things. And I think understanding that is really important. I think honestly, we could learn a lot from our AT colleagues about that. I think it's why it's really important to have really good relationships with our athletic trainers and other therapy colleagues, because there are so many things about how the body responds to things that you all get way better than we do. And that's really important, how those lines of communication open.
Well, we always appreciate a good relationship.
Oh, 100%.
It goes a long way, not just for us, but also just our patients.
Mm-hmm.
Oh yeah. And the patients can see it. They appreciate the communication, and they appreciate us talking to each other about, hey, this patient's hamstrings are still tight. They feel great, but they can't. No problem, nothing to worry about. Or, I think they've had a setback. Okay, no problem. We'll get them in next week. We'll get it figured out, and we'll get them back. It's a little hiccup in the road of recovery. We'll get them back to their recovery. So, but having that communication and having our therapy team, our ATs and otherwise, and also having the physician team open to that communication is really important, because sometimes people aren't, whether it's professional or personal communication or whatever it may be. But being open to that really makes everything better.
Oh, 100%.
So when you are going back to rehab, I was just realizing, obviously, that the spine doesn't just move in flexion and extension, but how much of an impact does rotation cause on a spondy?
Yeah, great question. So what's amazing about the spine, it has degrees of freedom in flexion, extension, rotation, left and right, bending left and right. And then one that people forget, it's compression and distraction. So it truly is these eight different degrees of freedom. It's why when we try to create an artificial disc, we're not even close to what the body has. It's so incredible, the design of the disc that allows all of this motion, and then the small joints called the facet joints and the structures of it's truly incredible. And so really the spine tolerates most of these motions pretty well with the spondylolisthesis, except for the extension. That's what it really doesn't like. So rotation, again, I wouldn't tell someone to go back their first week of rehab and twist left and right, bend forward, but I would say start gently with all of them. Just try to get some basic range of motion back. Try to get those muscles kind of moving again and breathing again, and just hold off. You'll notice it. And we'll usually tell them you'll notice it if you extend it too much, that you're going to feel it there. So they would have noticed that a lot of times even prior to being diagnosed with it. That's what really causing their pain, and so they will continue to be somewhat guarded in that activity.
For sure. So going through the entire rehab, it's that time. We're looking at the return to play. What do you look for to finally give that? All right, they're good to go. Let's get them back out there.
Yep. So I want them to be essentially pain-free. I want them to have rehabilitated themselves enough where they feel like they can play. Right? And that's what I usually tell them, because they want to go back first day, say, I'm pain-free. I want to be back out pitching, and say, look, even if you wanted to, you can't. You've taken 3 months off, right? Your body is not ready for it. Let alone your spine, but your core muscles aren't ready for it. Your shoulder, your elbow, your knees, your hips, whatever you're playing, the rest of your body is not ready for it yet. And what you don't want to do is get out there and disappoint yourself. And the way I kind of tell them is, like, don't disappoint your teammates. Honestly, the teammates are never disappointed. They're just happy to see that their teammates back out there, and is healthy and is recovered. But they understand that, hey, yeah, you're right. I can't get back next week and play at that level. I need the 6 weeks or 2 months to get myself back to the level that I can be a good competitor. If someone's just going out to swing a tennis racket on the weekend, that's a little different. Go out, hit a little bit, make sure you're comfortable, go through the motions. Don't go play a match, because you'll push yourself too hard. Because people, when we tend to get in that competitive environment, we start to lose track of what's reasonable sometimes, especially high-level athletes, right? It's exactly. It's why they're great. They go. But we have to then, keep them back a little bit from the competitive match or game or whatever it is, so they don't overexert themselves.
Oh yeah, I've definitely seen that where, I'll tell them like, hey, yeah, we're probably not gonna, do that today at practice, or like, you won't be ready for this game, but the next one they'll be like, but no, I'll just take it easy. I'm like, no, you won't.
No, you won't.
Don't lie to yourself.
Yeah.
I think
No,
your definition
and
of
I
taking it easy is different than my definition of taking it easy.
right. And I think they will, but then you explain to them, have you ever taken it easy in a game, right? Would you ever say, nope, I shouldn't go slide tackle that
Ex-
guy?
exactly.
Right.
That's what
They
it is. It's
never,
always there's that one ball. That one ball you're just
right,
gonna I'm gonna just go for it.
right. It's why they're really good athletes and I'm not, because I would
Yeah.
let's let the ball go past me and I'd wave and it'd be fine. That's not my forte.
100%. For sure.
Do you have any more questions before we have
No,
our action
I
item?
think it's time. I think it's time for the action.
So we always like to end on a great note. Just a little bit of action, and not just like slide tackle action, action that we can take into our clinical practice. Not that there's like this whole podcast, I
Yes.
think, has been such a great conversational
Mhm.
piece about spondies in general. But for today, just to wrap up, what advice would you give to someone rehabbing a spondy pathology for the first time?
I would say set a mental time frame of how you want your patient to move forward so that you don't fall into the trap of saying, oh, great, it's been 2 weeks now, you're there. You understand that this is a 6 week or 3 month or 2 month, whatever that time frame is that you think that patient needs logically from your first evaluation with them, and you allow that to progress naturally. Now, there has to be some flexibility, right? Sometimes people progress a little bit faster, a little bit slower, but I think having an expectation that rehabilitation takes time is important for everyone involved, all of the patient care team, but also for the patient and their family and their coaches and everyone else who wants them to get back, that this process is important because people don't see the muscles rehabilitating. They don't see the joints. They don't see the body mechanics. It's easy to come to my office and see a fracture and I say, put this brace on. That's so tangible. But it's the intangible rehabilitation is as important, and explaining that and walking them through that, giving them an expectation of the time and the effort and the gradual process that it tends to be, I think is really important for a lot of people.
Perfect.
I like it.
Yeah. I think that summed it up pretty well.
I think it did too.
Yep. So as we said just at the beginning of this episode, it just highlights just how easy it was to just have this conversation about spondies and make it, because spondies can get very complex when you start talking about the different types and, the certain restrictions, the time. And we were able to, Dr. Bhatia was able to make it very digestible, very kind of easy to keep, follow along and again, have a conversation about it.
Right. And I think at least when I think of spondies, I think of your typical swim athletes or gymnastics, which you're getting a lot of extension. I mean, maybe, your linemen.
Yeah.
But I really liked how we talked about just the generic sports that you don't think of as often.
Yeah, that's true.
And that this can really happen. Like, when do you notice that someone really can't keep competing at their high level?
Yes, and I loved how we highlighted how athletes don't stop.
No.
And when they do, that's bad. There must be a real big problem.
Right.
Oh, and also, I think we tried to make rolling backpacks cool.
Yeah, if you hear that, pass it on.
Yeah.
If you hear this, you heard it here first.
What the
rolling
cool kids.
backpacks are cool.
Yeah, I had one in elementary school.
Yeah, I had one in elementary school.
Yeah, because we're the cool kids.
So if you guys are new, we do every other episode as education or stories. This one was an education episode, so we're going back to our stories next week, where we take stories from athletic trainers all over the world, which we'll never get old saying. And we take different topics from our experiences as athletic trainers so you can learn and apply them to your practice to see what other athletic trainers have done. If you would like to submit a story or if you'd like to connect with us, go ahead and head over to our Instagram at AT Corner Podcast. We also have a Facebook group, facebook.com/group/AT Corner Podcast, where we're going to post an episode thread that you can comment on this episode and you can network with other clinicians. And lastly, we do have CEU episodes available for athletic trainers. So if you are interested in that, make sure you scroll down to the show notes, check out from Mass General Brigham, who is our partner, formerly known as Precision AT. And we also have MedBridge CEUs available. So if you are interested in a subscription, you can use AT Corner at checkout for $150 off.
And that should be for a year. I believe a year subscription. So it even goes into the next reporting cycle.
Sweet. So do you have anything else to add?
Yes.
Andy?
Can we get one more? Thank you for helping us showcase athletic training behind the tape. Bye.